So this is a study that we've just begun. Naji is the chief investigator, and then we have Elizabeth Ford and myself as co-investigators, and a whole host of other people working on it too. But I'll be telling you about it today. And the focus of this particular study is to look at people who go to memory assessment services but leave without a dementia diagnosis. So a different population to the one that we are used to looking at and used to talking about. So we know that memory problems are very prevalent in people in older adulthood. Subjective memory complaints, so when people experience a memory problem, even if it's not objectively measurable in a cognitive assessment, are pretty much one of the most common complaints that you get in older adults. And we see that in about a quarter of people. So a quarter of people aged 60 and over will report memory problems. Of course, not all of those people are diagnosed with dementia. The rates of dementia diagnosis are about 1 in 14 in people aged 65 and over. So what is happening to those people who have subjective memory complaints but do not receive a dementia diagnosis? So there was a push in, I think it's 2009, with a national dementia strategy to try and get those people to the memory assessment service, to try and push for early diagnosis of dementia so that people can get earlier care, earlier treatment, better outcomes overall. And this push was for people to seek help with those subjective memory problems, and also for GPs to refer people to the memory assessment services. And that's been very successful. The rates of people going to memory assessment have increased. But our question is, what happens to those people who are diagnosed but not with dementia or do not receive a diagnosis? So we know from an audit in 2019 that people going through memory assessment services, you would see about 2/3 diagnosed with dementia. Of those remaining third, most of them, or rather slightly over half, will be diagnosed with mild cognitive impairment. So they have an objective memory complaint, but not to the degree that they would be diagnosed with dementia. Another third of those individuals would not receive any diagnosis at all, whereas the remainder would normally be referred on to another service. So they might have primarily some kind of psychiatric problem or mental illness. But what happens in terms of care is another key point here. So we've got these people coming through, not everyone is getting a dementia diagnosis, but in terms of care, there is a pathway set up to deal with people who are diagnosed with dementia. So first of all, the GP refers them, the pathway starts, they go to memory assessment services, they have an assessment, a diagnosis is made, and that's where things start to change depending on the diagnosis. So for people who are diagnosed with dementia, they receive the diagnosis, they are assigned and they meet with a particular care coordinator. With that care coordinator, a care plan is agreed that will embed NICE approved care practices within it, and that should be reviewed yearly. So this is going to change very slightly depending on the particular memory assessment service someone is referred to, but in general, that is what a dementia pathway would look like. If somebody was diagnosed instead with mild cognitive impairment, it might be that there is no pathway set up to deal with these individuals. They may just be discharged with the diagnosis. If there is a pathway, it might be that they again get a care plan agreed, but they don't have a named care coordinator. And that is kind of the end of the line for them in terms of care. So they might have a care plan, but they are then discharged from the memory assessment service. If someone doesn't have a diagnosis of dementia or mild cognitive impairment, then they will be told that diagnosis. Maybe they get an onward referral if they have another complaint that has been identified through the diagnostics, such as brain injury or mental health impairment. But that again is the end in terms of memory assessment service care provision. And so this group of patients who do not get a dementia diagnosis, there's a very big what happens to them next. So they are quite often lost to follow-up. The memory assessment service will not keep them kind of on the books. So this group of patients are not being monitored for follow-up. In many ways, they're a neglected group in terms of what we know about them and the amount of research that's been done on this group. We don't know the characteristics of this group. We don't know the emotional impact and the health impact of going through memory assessment diagnosis, but not receiving a dementia diagnosis. We don't know what their beliefs were and their fears around that particular memory assessment. So lots and lots of questions about this particular group of people. And it's quite important that we do start to get this information, because we need to understand what the harm was of going through memory assessment, what the benefit was of going through memory assessment if you don't receive a dementia diagnosis. We need that information so that we can inform policy, inform best practice, and make sure that whether somebody has been diagnosed with dementia or they have memory problems and don't have a dementia diagnosis, they still are able to live well with those memory problems. So the current study that we're doing is to really try and address that gap in our understanding. We want to understand the impact of going to memory assessment, having memory problems, but not receiving a dementia diagnosis. And we want to explore what was harmful and what was beneficial about going through that memory assessment process without getting the dementia diagnosis. To do that, we are running a multi-site study, and BSMS and Sussex Partnership Foundation Trust are the lead site for this. But we have a number of other sites across the country. We've got sites throughout all of England, although we've got a good cluster in the North, Midlands, and then the Southeast. The sites that we have here are very varied, which is fantastic. We've got very diverse populations, diverse ethnic groups in the different areas that these trusts cover. And we also have a good range of people living in rural settings and urban settings that will be referred to these memory assessment services. So another kind of key thing to note with these sites is that they tend to be in places that are a little bit more under researched, a little bit less researched. So much of the research happens in Oxford, in London, but these are the sites that tend to be a little less well researched. So it's important to see what's happening in these populations. So this is what the study looks like. Very quickly, I'm going to go into this in detail, but we have a year-long study. We'll be giving people assessments at 0 months, so our baseline time point, and then again at 12 months. And we will be capturing people 6 weeks and no longer after they have been to the memory assessment service. So we're making sure to really get people on board very quickly and enrolled in this study. At the end, we're going to have nearly 400 people for whom we will have quantitative data. And then we're going to have a small sub-study of people for whom we'll have interview data. And I'll go over all of this in a little bit more detail. So we are looking for people who are aged over 50, have been diagnosed, as I said, or discharged without a diagnosis very recently, and importantly, don't have a diagnosis of dementia, but also their memory problems cannot be attributable to alcohol, brain injury, and other severe mental illness. So they can have mild memory problems that don't meet the criteria for dementia, or they can have subjective memory complaints or age-associated memory decline. They'll be getting a broad range of assessments, so a very in-depth questionnaire asking all about their attitudes to the diagnosis, their hopes, their fears, and this will be given at baseline. We'll be asking them all about their different lifestyle practices that they actually engage in, so how much sleep they get, how much alcohol they drink, how many social interactions they have and the quality of those social interactions, diets, physical health, a whole host of different metrics. But we're also going to be asking them what the memory assessment specialist discussed with them about lifestyle. So did the memory assessment specialist discuss cognitive stimulation with you? Are you satisfied with your current level of cognitive stimulation? Do you intend to change your level of cognitive stimulation? And the same again for diet, sleep, etc. And it's this intention to change that's really key for this baseline assessment in terms of the lifestyle practices. For a small subgroup of people at SPFT, we'll be asking them to come for an interview. And here we're looking for more information about what actually triggered the memory assessment referral in the first place. more information about their attitude to the diagnosis and how they intend to change their lifestyle based on going through that memory assessment service. And also, importantly, what do they think would have been useful in terms of post-diagnostic support? And all of this information is going to be supplemented by their medical history from patient case notes. At the 1 year mark, we'll be inviting those same people back to do the questionnaire and the interview for that small subgroup. And this time, lots of similar questions, but there are going to be additional questions around, have there been changes in your memory since you first attended the memory assessment service? Have there been changes in your diagnosis? Have you been re-referred? And then whether there are any changes in their lifestyle practices since that first assessment. And again, lots of information about how they now feel in terms of hopes, fears, etc., about their diagnosis a year previous, or their lack of diagnosis, as the case may be. Again, the interview will be digging in more detail into those same areas of interest, including changes to lifestyle practices. So we've got intention to change, and then whether people actually changed their lifestyle practices. So we are obviously collecting a huge amount of information in what is actually quite a simple study. So we're expecting, quite a lot of really rich information to come from this. What we hope to be able to do with that information is to identify triggers for referral and then potentially re-referrals that may have occurred in the year following that initial assessment. We want to get a really in-depth look of people's attitudes, their hopes, their perspectives in that year following memory clinic assessment, and evaluate any changes to their lifestyle practices, their social interactions, their medical health practices throughout that year, and then what the actual objective health and social outcomes were. What did they actually change about their sleep, as well as what they intended to change? And with this, the possibly most interesting element to people in the room is, what will this actually mean for memory assessments of practice? What we're hoping to be able to feed back to the memory service here is information about what the triggers were for referral, also information about when the memory assessment service professionals are specialists are speaking with the patient, what information are they sharing, and how much of that information is retained, and how does that affect people's lifestyles and their later outcomes. And all of this together might inform changes that are needed to the pathways, or additional pathways that really are needed within memory assessment services. So that is everything from me. These were some of the people that were involved. Couldn't even name most of the people, so I've just had to say the sites. Very big study. Hopefully we get a lot out of it, so watch this space.